Today, we have a couple of panelists that are going to be moderating and fielding some questions and have some topics of discussion as well. Panelists, if you would introduce yourselves, please.
Hillary, you want to introduce yourselves? They kind of heard from me a lot at this point.
Hi, good morning. I'm Hillary Conrad. I'm with the Department of Social Services, and I'll pass it to Samantha.
Good morning, all. Samantha Vasquez. I am the Chief of the Fiscal Policy Section at CDSS.
And hello all, again, Kush Cooper, Informatics and with Casey Family Programs. I am supporting this learning series. Okay, so let me. So we can open this up for the questions that you have. I do want to point you to. There's going to be some links that get dropped in the chat. They are a link to a presentation I did on day 3 of the statewide convening on, what was it? Was it June 3rd? Seems like forever ago. And, you know, it covers sort of why you should have a prevention-oriented system all the way through, well, how might this all shake out across levels of prevention and social determinants of health with regard to services and braiding funding? So point you to that. There's a couple of papers. Well, there's a website and a paper on the social determinants of health. And you know, why I like to keep the social determinants of health at the forefront is because it just anchors one in primary prevention, right? And if we're successful with primary prevention, that's going to get us the most quote unquote bang for our buck, as you heard Don and Claire share. We want to reshuffle where we're focusing our service delivery. And so organizing by the social determinants of health, while FFPSA funding pays more for the tertiary, right? There's other funding available for primary and secondary. And if you organize that by social determinants of health, I find that you cover all the bases for children and families about what we all need to live, work, and play in healthy environments and mitigate risk. And then there's also going to be a link later that we drop for you on how to register for our 720 learning forum. Okay, so those are all there in the chat for you. So some of the things that did come up, and so, you know, if your questions are related to that, then we'll just answer your questions. But there were questions that we got around needs for more California specific funding examples. What are the various California funding sources and the differences between them? And there's a couple of charts in that 6.3 presentation that show that, and you know, and I can draw on those as we need to. And then, you know, I think this is what's on everybody's mind. What are the funding sources for sustainability, right? And the bell that sort of goes off every time for me that when I hear Don and Claire talk is that, well, you know, given the federal funding has its constraints around it's mostly works on the tertiary side of prevention, and then federal funds are actually the ones that you don't want to supplant. I would think our local funds and how to use them creatively, our state funds, are going to be where we look for sustainability. And so those are the areas in which we're getting questions, but, you know, so we can, Hillary and Samantha and I can dialogue about that with you listening to us, but I'd rather open it up for your questions first before we start to talk at you. What questions do you have around funding sources, braiding funding, what's available, etc.? What brought you to this breakout room, I guess is another way to look at it.
I'm wondering, I hope you don't mind if I didn't raise my hand.
Not at all. We are a small group, so jump on in.
Okay, so I'm trying to make sure that my brain is working correctly when I'm thinking about like braiding funding and stuff. Because I just to introduce myself, I'm with Tulare County. I'm a policy and program specialist, and I'm the lead for the implementation of FFPSA parts 1 and 4. So I've had quite a bit.
Congratulations.
Yay. Yeah, I know. So, I'm trying to explain to people things like fiscal stuff that I've never really been involved in before. So, I mean, looking at it in this way, and I made a little example here, just to give an example. Say, we have a candidate or a client that's a candidate for foster care entry, that meets that FFPSA criteria, and so we have an evidence-based parenting program, say like Healthy Families America or something like that. But there's also additional issues that are covered, like, so say they also have a substance abuse issue, but they have Medi-Cal. So, and then they are in need of housing. So in my brain, the little hamster says that, parenting component could be covered under FFPSA, but the substance abuse would be covered under Medi-Cal, and housing support, we'd probably refer to our Bringing Families Home program, so that they could get the support they need, their well-rounded support, instead of just, the parenting component that's FFPSA. So we wouldn't leave the others out and just sort of push them to the side and say, oh, just go seek it yourself. Does that sound
Yes,
correct?
I think as a general principle, of course. And, these services are largely going to be delivered by community-based service providers, right? And they are very, very good at figuring out which part of their programming is funded by which funding stream, right? And they're also, they've become really good at not having that be seamless to the family. Right, the family doesn't need to worry about which part of my service plan is paid by what funding stream. And so to the degree that you have your local service providers at your planning table, they will help you sort this out. Of course, there have to be firewalls around, you can't disqualify them from future RFPs, et cetera, et cetera. So you have to be careful about that. But folks, I mean, the providers do this now. Right, it's going, well, which we could use this funding stream for this piece of it, this funding stream for this piece of it, especially if they're a kind of provider like an FRC, Family Resource Center, that provides a lot of those services. I just wanted to sort of just mention a nuance about, well, if they have substance abuse needs and they have Medi-Cal, then we'll have Medi-Cal pay for it. Well, if Medi-Cal would pay for it now, yes, right? But if your Medi-Cal funded service providers were at capacity for substance abuse, right, then you can bring 4E in to provide substance abuse services, of course, using one of the evidence-based practices for that family, right? If your Medi-Cal providers, if there are non-Medi-Cal certified providers, right, that are providing substance abuse services, and the family wouldn't necessarily meet those criteria for medical necessity, right, that are pretty stringent, then you could have a 4E contract. You could have a contractor that uses 4E to provide those substance abuse services, as long as they're provided with fidelity in a trauma-informed way and they're on the clearinghouse. So I just want to mention that nuance, because we ought to, until I remember that, I get confused all over again, which is, well, then Medi-Cal should pay for everything. Well, it's like, well, if it could, it would have. There's a reason it's not, right? Now, one of the things to keep in mind, and Don's voice rings in my ear a lot these days, that some folks do ask, well, our providers aren't happy with the rate that we're currently getting for this service. So could Title 4E be used to then augment the rate, for example? That's not a pair of last resort issue. That is a rate adequacy issue. And if you had a rate adequacy issue before Families First, you're going to have a rate adequacy issue after Family First, and that's got to get negotiated with the purveyors and the service providers. And Family First isn't going to address that rate gap that sometimes providers will talk about or purveyors will talk about. Regina. So does that help at all, Janet? Okay, good. And then Hillary, just before we go to anything you'd add to that?
The only thing I would add is that if you're not already talking to your behavioral health local provider, start having those conversations just like we are with DHCS, so you can speak through what that coordination is going to look like.
All right. And anything for you, Samantha, on that one? Nope. All right.
Nope, just, communication with your partners, I think, is key to all of this. I think that these kind of forums that we're having are a fantastic description of that. So absolutely, the more people you can get at the table at once to hear those conversations, I think will, take you far in that for sure.
Yeah, great. Thank you, Samantha. All right, Regina, floor is yours. Good to see you.
Thank you. Good to see you too. And I just wanted to underscore from a county perspective how key that point is in our planning. It's so much more than a nuance, right? It's like that is a total clarification. And to the extent that we can have that in a more formalized way, that would be an excellent tool for our local planning, because I think we're having all the right conversations with our behavioral health partners, but we're really stuck in that place of, if it's something that Medi-Cal could pay for, but our local behavioral health doesn't have the capacity, if they don't have the providers, if any type of capacity issue, like what's our obligation? And every conversation sort of gets stuck in that place. And so to the extent that I can go back and say, hey, well, here's how we can move forward, that would be incredible. And then it brings me to another question, and that is, so if that is indeed the case, then that decision making, agreements would happen on a systemic level, and then decision making would happen on a client level. So as you're looking at that client, that in Janet's example, which I appreciated, it's like, well, yes, this client also needs mental health services, and they are Spanish speaking, and as what I envision is that whoever that caseworker is would need to document, okay, we reached out to behavioral health, they don't have capacity, their waiting list is 3 to 6 months for Spanish speaking mental health services. Therefore, we have now met our commitment and our obligation and can use the 4E funded functional family therapy. And that needs to happen at that case level. And I'm assuming that would happen by the social worker, and then that effort would be reimbursed at the 50% rate. Mm-hmm. And so it is just, making sure that that's the right logic for thinking about it would really be helpful.
So is that the right logic? Is that your question, Regina? It sounds it sounds right to me. And if there are wait lists, right? If a family's not able to access services because there's a wait list, 4E can pay for those services until Medi-Cal becomes available. And then you can switch over to Medi-Cal when Medi-Cal becomes available. Right, but so 4E can be a bridge for those folks on a waiting list. So and that, from my my basic social work understanding, so certain fiscal things are above my pay grade sometimes, but that logic rings true for me, Regina. Now, I know that folks locally go, well, I don't believe you. Right, like how do I know that tax, we need guidance from the state, and we get that, but it is pretty clear from the law, right, what pair of last resort means. And again, if it's Medi-Cal could have paid for this child using this service in this location before FFPSA, then Medi-Cal should pay for it. If Medi-Cal couldn't, for whatever reason, then 4E can pay for it.
Well, I just want to add that ethically, it also makes sense to give the clients some service in the meantime while they wait. And so not in the absence of giving them nothing, that doesn't, as a social worker, feel ethically good at all. You know, that feels terrible. And so we're positioned in that same way too. So this feels great.
Right. And how many reentries could have been prevented, right? If families who were recently reunified or recently in a guardianship arrangement or an adoption arrangement didn't have a 6 months waiting list for mental health services, because we all know that it's touchy, right? When during that transition, right? That's when the support's needed the most. Right. And we I think that if we're able to strategically use 4E to fill that gap, we really will be able to prevent some reentries. That's the population that folks forget about, is the reentry population is easily a candidate for FFPSA funded services. All right. Phyllis.
Oh, hi. Glad to be here. My question is about training dollars, and in terms of training, not training specifically for EBP training, and specifically how to administer therapeutic interventions, but more for example, the child welfare workforce, or the workforce for other our partner agencies. Or for workforce issues in the community organizations. So doing some type of integrated training, for example. So are there specific dollars or provisions for that type of training, like generalized training for the hands-on folks?
Hillary, do you want to take a stab at that one with regard to sort of the vision, at least? I know the details need to get worked out, but, especially the things around the child welfare activities like candidacy determination and casework, et cetera.
I'll take a stab and then I'll pass it to Samantha. But number one, I would say that there is the block grant, and those monies can be used for training, and it does not have to be specific to the EBPs. And then you also have the admin dollars for 4E that can be used for training as well. Samantha probably knows more of the specifics, but just a high level answer.
So yeah, I mean, I'm going to admit I was not the one who wrote the letter. My staff was. We have a lovely 14-page letter. I put the link in the chat that talks about the training dollars that are available and which types of training should be claimed where. It is CFL 2122, I believe. Let me double check that.
It's 2122-110.
Thank you, 110. Thank you very much. So that gives some really detailed and specific information regarding the types of training and where to claim it to. Certainly, if you have any specific questions when you get into that CFL, there's a link to contact my section, and we'll be happy to answer any specific questions that you have.
All right.
And say that there's, I was going to say that we do have separate codes for specific child welfare. And then, I'm sorry, I'm getting a message saying my internet connection is unstable, but we do have separate codes for child welfare and then a separate one for the providers.
Oh, okay.
And in general, the way I think about it, Phyllis, is there's two kinds of training, right? There's the training to deliver services, both evidence-based and non-evidence-based, right? And then there's the training to do casework, right? Mm-hmm. Given that, those are distinct. They're connected, but they're distinct. So both need to get figured out. And it doesn't matter who's going to be providing that. So you could have a child welfare worker providing, say, motivational interviewing, right? And they would need to be trained alongside any private provider that's going to be getting certified in motivational interviewing, right? And so joint training, I mean, it would make no sense to have two trainings, one for the 5 child welfare workers that are going to be providing motivational interviewing, and then a separate one for community-based providers. So to the degree that we can figure out that to have those trainings simultaneously, that's going to save us cost. Yeah. then there's the matter of the community pathway, right? And should a county elect to use a community pathway, then your community-based providers are going to need to be trained in things that wouldn't normally, and I say that in quotes, be done by a child welfare worker, like an assessment, a recommendation for candidacy, although the final determination rests with the 4E agency, right? So if you're going to elect to do a community pathway, that part of the training needs to be done jointly as well. So that's just that's the way I think about it. It doesn't matter really who, it's what's the service being provided, and let's get all the folks together that are going to be providing that service or that case management activity. And I've found that in trainings that I conducted or I've been in, particularly around things like child and family teams, having private providers and child welfare workforce in the same place and sort of discussing their experience delivering those services really just enhances the experience in the training. You know, it makes it more relevant, not less relevant, to actually have both of those sectors in the same training.
Yeah, and to go with what Kush is saying, I think that fantastic idea. And there is a way, as long as you know who is in those trainings, there's a way to separate out the claiming for that. So they are two different distinct training pots for different populations. But certainly there are ways to break that out. So again, any questions that you have when you kind of get into that place, please reach out to the fiscal systems email box, fiscal policy, and we will help you with that.
And I will add that the current plan is that the state is going to provide the training that's related to all of the, I'll call it the foundational pieces of FFPSA. So that would be assessing for candidacy, looking at what the case management has to be, what has to be in the prevention plan, all of those pieces the state would provide. It's the EBP training that at this moment, we're not really sure if we'll be able to pick up those costs.
Okay, thank you so much. It was very helpful.
You're welcome, Phyllis. Right, there's a question in the chat from Marissa. Marissa Green from Yolo County. It says Yolo County is a county that has taken an oath of poverty and doesn't receive funding for child welfare admin costs. They receive traditional funding that all CWS agencies receive. Are there any other counties that are positioned similarly? And if there are, Yola would love to hear or be pointed to connecting with them about how they're thinking about getting their planning started. Are there any folks here and do our CDSS folks or anybody else in this community sort of have any guidance for YOLO or any place to point them?
I have never actually heard of an oath of poverty from a county. Could you give a little bit of background on that, Marissa?
Yeah, so Yolo County has taken an oath of poverty. That's probably why we're right now on, if you Google us, we're the most impoverished county in California. And we think that there's some reasons for that. Maybe our data from UC Davis, because they are including that data from our population, from our college students. However, as it is, they have taken an oath of poverty, and this goes back years and years old because of the ag community and ag culture. They don't want to take certain tax from the constituents. And so it's something that they have kind of dedicated to their community and their constituents. So they don't want to increase the tax on their community. And I think it's really almost grandfathered in. There's not a way for them to necessarily change that through the Board of Supervisors, the way I understand it. And so there's not much that we can impact in that way to say we are asking for more money. We have to get it through realignment or, traditional funds. We have to just move it around and make it work. So it's not like we're Marin or Alameda County where there's dollars that come in. It doesn't happen that way. Does that help?
Yes, thank you.
Mm-hmm.
And Marissa, that is it seems like it sounds like a unique situation, but it may not be. So this is being recorded. So we've noted the question, and we'll sort of, take that back and do, ask around as we start to put it in the answer, put it in a written document later.
And any
It's an
technical
interesting
assistance around that.
situation.
Yeah, any technical assistance around that, or any counties that are planning around that, we're happy to connect if you can connect us. Thank you so much.
And there's the 4E funding, right? And so this is the other thing that I have to remind myself often, which is there's FFPS, right? And then there's FFPSA. Okay. FFPSA speaks to the 4E funding available for prevention, right? That the legislation made available in 2018, right? FFPS, which includes FFPSA, is actually the state block grant, right? And you can use the state block grant for things over and above what 4E can pay for. And so, and I know the allocations are different depending on the different sizes of the counties, so there's your share of 199 million, right? That can be used for prevention. And that's not speaking to the other funding sources like CB-CAP and ARPA CB-CAP or the other existing funding streams for prevention. So we want to just make sure that we know that FFPSA is a finger on the hand of prevention funding. FFPS is much bigger. The A is just additional 4E funding for the tertiary part of things, right? That you can bring that you can bring to bear. So we've got to keep the FFPS, which is bigger, distinct from FFPSA, which is part of FFPS. But that's just a 4E spigot, FFPSA.
That's helpful. We also struggle with the Fed non-Fed rate as well here. So that's an additional challenge. But Molly, who is working on this project in tandem with me, has a question. I wonder what her question is. Probably going to be very poignant. So I want to hear what she's going to say.
Yeah, actually, it was speaking to, again, looking at the state block grant and that ACL, and also in parallel the CDSS's plan that they've submitted to the feds, and sort of helping to differentiate some of the services and candidacy. And so, and you had talked about this a little bit earlier and touching on it now as well. And I was trying to kind of think through, so the state block grant dollars and the plan that counties have to submit with the primary, secondary, and tertiary, right? So for the CPP, it sounds like there's a sort of continuum of services that we need to identify. And then could you speak a bit more to the actual 10 EBPs and well-supported EBPs that have been selected? And our folks, as the states are saying, like, no, those EBPs are really fitting with the tertiary continuum, and that counties, opting in and developing the CPP plan have to then also identify more broadly primary services as well as secondary services. Is that, or can some of these EBPs fit within those primary and secondary? Does that make sense?
It does make sense. The way I think about it is it's depending on whether the child and then the child's family members meet the definition of candidacy, right? So if they meet the definition for FFPSA candidacy, right, you can provide brief strategic family therapy using 4E, right? If they don't meet the criteria for FFPSA candidacy, but you want to provide them with brief strategic family therapy, you still can, right? You've just got to use other funding to do it, right? So I'd be checking, okay, are they an FFPSA candidate first? We don't want to not serve a child and family because they're not with a particular EBP because we think it's right because they're not an FFPSA candidate. So your EBPs the same EBP can be brought to bear across your levels of prevention. It just depends on who's going to pay for it, depending on whether they're an FFPSA candidate or not. And I see Hillary nodding, so that must be making sense. That's how I think about it.
Yeah, and that's the way that I would think about it as well. And I would just also remember that you don't have to have a ton of EBPs. Really, as a requirement for your plan, you really only have to have one in order for it to be considered a comprehensive prevention plan that you're going to be able to draw down those 4E dollars for that particular EBP. So we don't want counties to stress about this idea that they have to be delivering every EBP that is in the state plan.
Yeah, in fact, just getting one EBP up and running, for those of you that have done it, you know what that implementation is like. So, you know, start small, one EBP, a particular population in a geographic area. That's enough to start. We are at 10:31. I got my friendly nudge from our Caltrin facilitator. So, and I know we have hands up. One go down. Regina and Francesca, do you still have questions?
Also, the breakout rooms are going to auto close. I saw the message come through. So Francesca and Regina, if you would drop that question in the chat directly to Kush, just so that we don't lose track of those questions, that will be important.
But really quickly, in the next 30 seconds, I guess they have to drop it. And then there's ways to submit questions through